Good evening and welcome to the St. Augustine Center for Ethics, Religion, and Culture at the College of Our Lady of the Elms. I'm Dr. Peter DiPergola. Sean is Family Chair for the Study of the Humanities, Associate Professor of Bioethics and Medical Humanities, and Executive Director of the St. Augustine Center. I have the distinct honor of hosting tonight's inaugural Distinguished Lecture in Culture. Please note that tonight's event is being recorded and will be uploaded on the Elms College YouTube channel within the next few days. Immediately following tonight's lecture, there will be an opportunity to engage directly with our distinguished speaker. Please feel free to submit your questions via the Q&A box at the bottom of your screen. We ask that you please avoid using the chat box to submit questions. Before we begin tonight's historic event, let us take a moment to consciously place ourselves in the presence of God. To that end, it is now my pleasure to introduce Naomi Laviolette, junior biology major in bioethics and medical humanities and ethical leadership double minor, who will offer a prayer to St. Martin de Porres, patron saint of social justice and of public health.
To you, St. Martin de Porres, do we prayerfully lift up our hearts, filled with serene confidence and devotion, mindful of your unbounded and helpful charity to all levels of society, as well as your meekness and humility of heart, we bring before you our petitions. Pour out upon our families the precious gifts of your generous intercession. Show to the people of every race and every color the paths of your unity and of justice, and implore from our Father in heaven the coming of his kingdom, so that through mutual benevolence in God, we may increase the fruits of grace and merit the rewards of eternal life. Amen.
Thank you, Naomi, for that beautiful centering prayer. It is now my pleasure to introduce the 11th president of the College of Our Lady of the Elms, Dr. Harry Dumais. Dr. Dumais has served in higher education for over 20 years. Prior to joining Elms College, he held senior and executive level positions with St. Anselm College, Harvard University's Paulson School of Engineering and Applied Sciences, Boston College's Graduate School of Social Work, and Boston University's School of Engineering. Dr. Dumais serves on various boards, including the New England Commission for Higher Education, the Association of Independent Colleges and Universities in Massachusetts, the Association of Colleges of Sisters of St. Joseph, the Boston Foundation's Haiti Development Institute, Pope Francis Preparatory School, Build Health International, and Norwich University. Please join me in welcoming President Dumais.
Thank you, Peter. And good afternoon, everyone. On behalf of the students, faculty, staff, College of Our Lady of the Elms, it is an honor to welcome all of you to the St. Augustine Center for Ethics, Religion, and Culture Distinguished Lecture in Culture. Now, let me start by thanking everyone who contributed to make this distinguished lecture possible. Of course, Dr. Peter DiPergola, Executive Director for the St. Augustine Center, Professor Michael McGravy, Director of the Institute for Theology and Pastoral Studies, the Center's Advisory Board, all faculty and staff and students who contributed to making this event possible, all supporters of the St. Augustine Center. And now let me say a particular thank you and welcome to our inaugural speaker, Dr. Thea James. You will hear a summary of Dr. James' truly impressive background later. Among Dr. James' titles, one that caught my attention is that she is Vice President for Mission. That speaks to the core of her work, which is to advance healthy outcomes for all, particularly those who have been traditionally disadvantaged by our healthcare system. Welcome, Dr. James, and thank you for being with us today. Last year, in the middle of the pandemic, the college launched the St. Augustine Center for ethics, religion, and culture. The St. Augustine Center is one of the most visible ways through which we affirm how the Catholic intellectual tradition affects what we do here at Elms College. Father Robert Mbelli, a theologian at Boston College, states that, quote, "The Catholic intellectual tradition is the joyful celebration and the continuing exploration of what St. Augustine called the beauty that is ever ancient, ever new." Yet, while we celebrate enduring beauty, another Boston College theologian, Father David Hollenbach, states that, quote, "Our country and our globalizing world are also challenged by deep inequalities and poverty. The university is a major venue where ideas about the meanings of justice and their relevance to our life together must be explored," end quote. Both of these statements find their relevance in the examination of our contemporary culture. We find beauty in the expression of music, literature, poetry, the arts, and the celebration of the diverse ways through which we show our humanity. At the same time, we would be blind not to observe inequity, injustice, and misery within our society. All of these topics find their relevance in the St. Augustine Center's examination of culture. It is therefore quite apropos that tonight's conversation will address the racial, ethnic, and/or cultural inequalities illuminated by the COVID-19 pandemic. It is also very much in keeping with the founding mission of the college. The Sisters of St. Joseph, our founders, dedicated their lives to constructing a community that aims to improve the lives of all people. That ideal serves as the moral compass which guides us in the direction of compassion, understanding, and love. And we continue to follow in our founders' footsteps, forging a path towards justice and equity through substantial community programs and academic initiatives like this distinguished lecture series. So again, thank you all for being with us this evening. I hope that you are engaged and challenged, engaged to think about the big questions, challenged to envision how we all might, in our own way, advance a just and equitable culture, one that restores our sense of wonder at a universe charged with the glory of God through each and every one of God's children. Please enjoy the program and your evening. Thank you.
Thank you, Dr. Dumais, for those remarks. It is now my pleasure to introduce the Vice President of Academic Affairs, Dr. Walter Breaux.
Thank you, Dr. DePergola. Thank you, Dr. Dumais. Good evening, everyone. I will echo Dr. Dumais by thanking you all for honoring the college and honoring the St. Augustine Center for your presence here this evening for the inaugural Distinguished Lecture in Culture. Dr. James, thank you for being here and giving us this opportunity to hear your thoughts and perspectives on the singular event which we have all been living through, shining a light on the racial, ethnic, and cultural inequities highlighted by the COVID-19 pandemic. Prompted by today's lecture, I revisited a publication from last year by Dr. DePergola on the ethical guidelines for the treatment of patients with COVID. What was clear from Dr. DePergola's white paper and from the work of the Crisis Standards of Care Advisory Working Group, and certainly individuals such as yourself, Dr. James, is that no matter the severity of a situation or the scarcity of essential resources, it is essential that, in the words of Dr. DePergola, there is the need to address the moral considerations inherent in caring for the patient. And in a time of crisis, fairness is more important rather than less. Dr. James, as Dr. Dumais said, your being here today serves both the mission of the college and the work we do to prepare the next generation of ethical leaders, including ethical healthcare leaders. As Dr. DePergola stated in a proposal for a bioethics and medical humanities program here at the college, there must be an awareness and appreciation for the whole person in medicine, reminding us that our explicit focus in healthcare should include the experience of patients as human beings, not just as particular body parts or pathological processes. The tireless work of individuals like the two of you ensured that through your insistence, even during the pandemic, the standards of care reflected the importance of respecting the human dignity in each person, each patient, without distinction. Dr. DePergola, thank you for the work you did to get us ready for this afternoon's inaugural Distinguished Lecture in Culture. And thank you once again, Dr. James, for spending some time with us this afternoon. I am also very much looking forward to hearing your address. Dr. DePergola.
Thank you, Dr. Bro, for those remarks. Late on a Wednesday evening in March 2020, I received an email from the Massachusetts Department of Public Health to inform me that I had been appointed by Commissioner Monica Barrell to the MDPH Crisis Standards of Care Advisory Committee, which was tasked with creating guidance for how and to whom to allocate scarce medical resources, especially life-sustaining medical treatments, in the event that demand outstrips supply due to the catastrophic disruption and acute spike in critical care inpatient hospitalizations caused by the COVID-19 pandemic. The committee included medical experts and bioethicists from across the Commonwealth, representing both large academic medical centers and small community hospitals, and was charged with expeditiously developing recommendations for ethical, equitable, and transparent guidelines for providing acute care during a once in 100 years crisis. No pressure. While I had never imagined my life as a disaster bioethicist to that point, I did look forward to being part of a moral think tank with close colleagues at Harvard, Tufts, BU, Mass General, Beth Israel, and Boston Children's. Yet it was not from my Ivy League colleagues that I would benefit most, but rather from someone with whom I was yet to be acquainted, someone who would teach me everything I needed to know about what I didn't, but most urgently must know about healthcare disparities. In her gentle but powerful voice, she would remind all of us on the committee, in her own way, every time we met, that it was our mission to ensure that the tragically difficult decisions with which we had been tasked must remain as clear, transparent, and objective as possible, that they must be based on biological factors related only to the likelihood and magnitude of benefit from medical resources, and that they must, at all times, minimize inequitable outcomes. She passionately advocated that factors with no bearing on benefit, such as race, disability, gender or sexual orientation, gender identity or ethnicity, ability to pay or socioeconomic status, English language proficiency or perceived social worth, perceived quality of life, immigration or incarceration status, homelessness, or past or future use of resources were not to be considered by providers making allocation decisions. Her clarion call to remember who we were and, more importantly, who we were called to serve was nothing less than our anchor through the choppy waters of life and death decision-making. It is my great honor and privilege to introduce you to the bearer of that gentle but powerful voice tonight, our distinguished speaker, Dr. Thea James. Dr. James is Associate Professor of Emergency Medicine at Boston University School of Medicine and Boston Medical Center, where she also serves as President of the Boston Medical and Dental Staff, Vice President of Mission, and Associate Chief Medical Officer. She directs the Violence Intervention Advocacy Program at BUSM BMC, is a founding member of the National Network of Hospital-Based Violence Intervention Advocacy Programs, and was an appointed member by Attorney General Eric Holder's National Task Force on Children Exposed to Violence. When Dr. James is not leading one of the most complex healthcare organizations in New England, she can be found caring for patients as an attending emergency medicine physician. As Vice President of Mission, Dr. James works with caregivers throughout her health system to coordinate and maximize relationships and strategic alliances with a wide range of local, state, and national organizations, including community agencies and housing advocates, to address the full spectrum of patient care needs. Her goal is to foster innovation and effective new models of care that are vital to the flourishing of underprivileged communities. Dr. James served on the Massachusetts Board of Registration in Medicine from 2009 to 2012, where she was chair of the licensing committee. She is the recipient of numerous awards for healthcare leadership and service, including the Boston Public Health Commission's Mulligan Award for Public Service, the Suffolk County District Attorney's Role Model Award, the Boston Business Journal's Healthcare Hero Award twice, the Schwartz Center for Compassionate Care Award, and the Boston Chamber of Commerce Pinnacle Award for Women in Business. A graduate of Georgetown University School of Medicine in the Emergency Medicine Residency Program at Boston City Hospital, Dr. James' passion lies firmly within domestic and global public health. Within the Massachusetts Department of Health and Human Services, she is a supervising medical officer on the Boston Disaster Medical Assistance Team and is deployed to provide medical care after various public health disasters, including to New York City after the terrorist attacks of September 11th, 2001, to New Orleans after Hurricane Katrina in 2005, to Bam, Iran after the earthquake of 2003, and to Port-au-Prince, Haiti after the earthquake of 2010. If this doesn't embody the spirit of the Sisters of St. Joseph, I'm not sure what does. Please join me in extending the warmest possible welcome to Dr. Thea James, who will deliver the inaugural Distinguished Lecture in Culture on the topic of racial, ethnic, and cultural inequalities illuminated by the COVID-19 pandemic as it pertains to scarce resource allocation in equitable healthcare delivery.
Thank you so much, Peter. Thank you so much. I'm really grateful to you for your kindness and generosity. So I want to share my screen, but what I want to do today is to sort of present exactly what you said, and also to give context for it. And I'm going to give some examples of how we are looking forward and what journey we're on, and the very unique, I think, approach that we are taking to address this idea of equity, because I think we're coming at it from a different angle, but I'll explain more when I get there. So now let me just share my screen. See, okay. All right, so the title of this will make sense as I go along. I have to move these things around here. Sorry about that. I'll figure it out. Okay, here we go. So I think I wanted to start out by telling you a little bit about our healthcare system, Boston Medical Center healthcare system. We are the largest safety net hospital in New England, which means that a majority of our patients live at or below the federal poverty line. More than 80% of our patients are publicly insured or uninsured. 1 in 4 of our patients report having housing insecurity. 77% of our patients identify as non-white. And we also have a really deep history of partnering with various different community organizations for various different reasons. But there was that, we've always been creative and innovative because of the population we serve. But at some point, we began to ask ourselves a very ethical question. And that question was, what is the role of a safety net hospital? Is our role charity exclusively into perpetuity, which really changes no one's life? We're just propping people up. We're just propping them up so that they won't fall down, but we are not really giving them an opportunity to step out of the line of need and to thrive independent of those gap fillers. Is that our role, or is our role equity? And that is the question that we asked ourselves, and hopefully by the end of this today, it'll be obvious which path we have chosen. So as I said, we've had decades of creating innovative types of programs, like the one at the top, Children's Health Watch, is one of the, that organization was started here and has one of the largest bodies of data around pediatrics and families in the country. We have a Grow Clinic for children who are underweight for various different reasons. We follow them through their life course until I would say early adulthood. And by that, I mean college age and that type of thing, or high school age. The Medical Legal Partnership was born here at Boston Medical Center, which is bringing attorneys into the healthcare setting to help address some of the structural barriers that create some of what we see coming through our doors, which are health problems, but really are downstream consequences of root causes upstream. And those root causes are generally inequities. Then we have a violence intervention advocacy program that does something very, very similar. And the question we asked about the violence intervention program when it was time to start that program was, how did this happen to these young people? I often would look at them and say, how could that happen to them and not to me, given that I didn't grow up very different from the way they did? And, one of the most, when the mayor asked us to start this program, there were only 3 hospital-based violence intervention programs in the entire country. And one of them has started to publish. And I decided to look at, one of those first papers that was published on measures of success. And I noticed that what they were measuring as and considering successes, they were measuring things like re-injury, reincarceration, dropped out of school. And I just couldn't understand why they set such low bars. I also couldn't understand what their objective was or what they were trying to achieve. So I only knew that we wouldn't do that. I didn't know what we were going to do, but we wouldn't do that. We decided we would set high bars. And I just also want to add that one of the most striking things to me that helped me and helped us to decide how we would shape that program and what our objectives would be was noticing the tattoos on those young people's bodies in the trauma room, sometimes alive, sometimes not. But the tattoos were very telling. The tattoos said things like, born to be hated, dying to be loved. Living is hard, dying is easy. Or death is nothing, but to live defeated is to die every day. And unlike what most people's perceptions are of young people, particularly people of color who come in with gunshot wounds, people think that they are bad people, but in fact, what the tattoos taught me and told me is that these were young people who were hopeless. And then Street Cred, which was created by 2 pediatrics residents, where they do taxes for families in the pediatrics clinic. But what they're really trying to do is to put a spotlight on earned income tax credit so that people will, get the benefit of that. And it's only about 4 or 5 years old, and they've gotten back somewhere between $7 and $9 million for families. and then the Center for Urban Child, which is really empowering families to define their own priorities and to design their care based upon what matters to them. But no, all of those things we have in place and have had in place, it has not changed the outcomes. Nothing actually changes. And if you look at these data here, I'd actually tell you to ask you to think about this. I will bet that anyone watching this would say, what else is new? You could predict this. If someone said they're going to study, each of these conditions, you would expect, if it's measured demographically, you would expect it to show just like this. When some people say, why do we care? Why do healthcare systems care about this? We care about it because we are ineffective when we are trying to use what we have been taught in medical school and other allied healthcare professions to do when people show up with certain types of conditions. But the root causes of these conditions are things that we're not taught about. You know, for example, there are direct correlations between health and wealth because people who have, all the data show that people who have lower income have lower health status. And by the way, so do their children because they're just mere beneficiaries of their parents' resources. They also, you know, they have limited resources, so they're prioritizing those resources to do things like to secure some sort of, you know, stable housing, to feed their families, to keep the lights on, paying utilities, and they certainly cannot prioritize health. You know, they can't even prioritize, you know, having money to get to spend on transportation to get to a medical appointment. So the doctors are prioritizing medicine and disease, and the patients are prioritizing survival. And so the two just don't match up. And so it winds up being a vicious cycle of instability because literally the same people come in with the same problems over and over again. They're, you know, they come in unstable, disease out of control. We treat them and reset them back to baseline, but unknowingly, we're basically just discharging them back to exactly what's driving it. And so other things that fit into this category of, you know, health and wealth, people with lower education status or abbreviated education status, these people also have lower health. They also have, people with lower income also have shortened life expectancy. For example, the difference in life expectancy between where I'm sitting right now and just right up the street is more than 33 years. And then in 2017, the Boston Globe did a series on race. And one of the things they looked at was the median net wealth gap. And the median net wealth gap in 2017 between whites and blacks is $247,000 for whites and $8 for blacks. In fact, the Globe had to print, this is not a typo. And so no one ever interrogates these highly predictable disparities and gaps. Nobody ever asks the question, why is it predictable where the worst things that can happen, like these things at the bottom, lower income, premature death, low education, life expectancy, and high rates of homicide, why those things are predictable and in what neighborhoods, you know, you can predict they will occur all across America. Why does that happen? We just accept those things as the status quo. And the problem with that is when you're thinking about things like equity, you have to begin with inequity because there's a reason why those things happen in those neighborhoods and in those zip codes and don't happen elsewhere. And we're not necessarily taught that history when we are, you know, coming up in school, and certainly not in healthcare curriculums. One really, I think, pivotal point in time was back in the 1930s, and it was right after the Great Depression, and to some degree before that. But the economy was in a really bad place, and our president at the time, President Roosevelt, was trying to resuscitate our country from this terrible economic state we were in. And he began to create pathways for people to build wealth in the country. And as many of you may or may not know, one of the most common ways to build health and to build wealth in America is through home ownership because of the benefits of home equity. So it was indeed a brilliant plan. He even subsidized developers to build more housing, you know, to increase supply, to have, so that more people would have access, you know, to this wealth building pathway. But he also, at the exact same time, there were policies established that said things like to the developers, we will subsidize you to build these houses, but only if you agree not to sell them to Black people. And what they did was they drew lines through communities all across the country And if you lived behind those lines, it's called redlining. If you lived behind those lines, you didn't have access to that wealth building pathway because you couldn't get access to the financial services. For example, if you owned property or homes or whatever behind those red lines, you were deemed a risk, a financial risk. So you could not get like a mortgage or whatever. And even today, you know, these things, there's modern day redlining as well, but it's, you know, it looks different, but it has the same sort of inequities that prevent people from actually building wealth and multi-generational wealth in this country. And so the interesting thing about those maps from redlining is those maps actually match the COVID maps of 2020 and today across the country. And it goes to show how when you have an intentionality to create something, it becomes a self-fulfilling prophecy and it perpetuates itself over decades. And so that one point in time really created two distinct socioeconomic populations, and it exists to this day. And so it actually played out in our hospital. As I said in the beginning, this is a safety net hospital. So most of our patients live behind those red lines, you know, even today. Our hospital was the first hospital to sort of tip over from the volume that we received at a very, very rapid rate when COVID was first starting in 2020. If you looked at this, it was sort of like a really, like a tsunami. It just like every day, the numbers went up and up and up and up. And on that day, as you see at the bottom, there was one day where we had to transfer out 9 people, 9 patients to other hospitals. It was the only day we had to do that, but it was happening so quickly, and we were taking every single space we could find and convert that into a care space, a clinical care space. But at some point, we sort of just ran out of room, and people were incredibly sick. People would come in the hospital, you know, sometimes when I was in the emergency department, you know, you look at the computer to see what new patients have come, and so you know what room to go to, and you read about the patient, and it might say something like 42-year-old man who was diagnosed with COVID 2 days ago, now is here having trouble breathing. And you might go in the room, and within 20 minutes, that person is like crashing and burning and, you know, winding up on like a ventilator. So it was really, really, really a really intense time. And our patients come from the communities that are highlighted there in blue, and that map is a redlining map as well. And every week we would produce a daily report, you know, from the COVID data, and we would look at, I call it sort of like a map, you know, it's sort of like a weekly, a real-time map. And this map is actually sort of like a textbook of the things I was just talking about. For example, the majority of the patients who came in during that time, actually 80% of our hospital admissions during that time and discharges were people who had COVID at that time. The red circles, that's that redlining map I just showed you. That's where the majority of the patients came from. The majority of them had high school educations as you know, as their highest level of education. A majority of our patients were people of color, as you can see, and also a majority of our patients had comorbidities. And for us, you know, for our patients with comorbidities, they're not like classic patients who have comorbidities, like they have multiple medical problems, you know, like hypertension, you know, diabetes, heart disease, kidney disease. Those are usually things you might find in maybe the 7th and 8th decade of life for people, but our patients have those things in their early 40s. Those are the type of medical conditions our patients face. I mean, that's what our patients look like. That's a snapshot of what our patients look like. And so, you know, everyone talks about mistrust of the healthcare system. And lots of times people like to refer to the, you know, Tuskegee, you know, or Henrietta Lacks or something, you know, some things that happened, you know, some time ago as to why people don't trust the healthcare system. But I actually believe that it's less of that. I mean, some of that, but more of what's happening in real time. It's like what your experience was like in the healthcare system last month or 2 weeks ago or yesterday or maybe even an hour ago. That's where it comes from. And I'm bringing it up at this point right here because everyone knows, and I just showed you as well, where and which populations, which zip codes had the highest rates of death and illness from COVID. But when the vaccines came online, that is not where, at least in our city and in some other cities, that is not where the vaccine sites were deployed or set up. And so we realized we actually had two problems on our hands when the vaccines came out. Number one, hesitancy, people not trusting. And by the way, not prioritizing the communities that suffered most when the vaccines became available is another example of how mistrust is created. And so we had the hesitancy issue, but then we also had an access issue. So we put together an entire team, and part of it and was led by our Vice President of Community Engagement and External Affairs, Trina Cherry, and she and our team of people in the hospital operations and strategy, those various different departments, and as well as our data science and analytics teams all got together. And the one thing we did was we had decided we wanted to have more community engagement. Even pre-COVID, we had made that decision, which is why we had hired Trina in this role. Because in most cases in hospitals, when you invite community engagement, it's usually one person that gets invited to some committee to satisfy the governance, which really doesn't leverage the value that person can actually bring and contribute, because there's a power dynamic. It's that one person and then all of us. And so we decided to make it the other way around. And so we started hosting Zooms. And Trina reached out to various different leaders in the community. She began with faith-based leaders, and then people in social clubs, various different ethnic groups, all kinds of groups. We had multiple Zooms. And we had infectious disease doctors of color and one of the directors of senior leaders of pharmacy to provide education about the vaccine. But the rest of the Zoom calls would all be about asking the community members to help us to identify and decide where these vaccination sites should be. What should they look like? What should they feel like? And so those community members, would walk around with our strategy teams, with our operations people, and do site visits. And ultimately, it resulted in setting up 6 vaccination sites in the community. The state actually supplied us with the vaccine to be able to do that. And so here's what I was talking about in terms of the hesitancy. So we were also surveying people electronically in the community, and we could see that, like Black people in the community were 2.5 times more likely to say that, they wouldn't get the vaccine, or they were undecided about getting the vaccine. But then we realized, oh my goodness, these are community members, but they're also our employees who live in the communities. And we found the exact same thing there. If you look here in this colored column here, you'll see only 36% of Black or Latinx or Latino people versus 72% of white people who were more inclined to getting vaccinated. And so, as I said, the first people we spoke to were faith-based leaders. And so our very first site was set up at this church right here with Bishop Borders. And, we had people from the hospital staffing the sites, but everything about the site, every site had its own sort of flavor, and its own sort of feeling and culture to it. And it enabled us to actually vaccinate at a higher rate, or that particular population at higher rates than the state sites. And, we think it was because of access. We also think it was because designed by them. And, there was more trust in it. They were more involved in it. And so we think that's how we had so much success. But again, the state did provide us with the vaccine that enabled us to be able to set these sites up. And so we had really deep analytics going on at the same time. We had another sort of a vaccination dashboard that actually comes out every week. Sometimes it's twice a week. And, we would be looking at all the different vaccination sites and looking at everything. It was very dynamic. We sort of changed things around in those sites based upon what we noticed every day. And looking at things like vaccination sites by race, for example. And then also looking at non-vaccinated patients. At this point, we're also doing pop-ups. We're doing more pop-ups than anything at this point. We actually know, we have these heat maps. We know which houses, which people in which blocks and which neighborhoods have not been vaccinated. We do door knocking. Somebody will show up at your door, with an educator and the vaccine. And so we've just been following this, it's, very, very closely throughout. So these are pictures of the governor at the first site we had. Next to the governor is our attorney general. She's at one of the other community sites. And at the bottom is our city's chief of health and human services in the mayor's department at yet a third site. And here again, you can see the data in terms of the thing about equity is about intentionality. It's about where you set the bar. Wherever you set the bar and whatever intentionality you aim for, that's what you'll achieve. It's like anything else. In hospitals, we set out to achieve things like, lowering infection rates, hand washing and all these things, which actually, wind up counting a lot towards how hospitals are rated and all these various types of things. So we do these things with great intentionality to achieve an outcome. And the same thing can happen for these kind of initiatives. We did a really robust communications plan. This is our internal plan right here, where we had various different employees and doctors and on our intranet site, and people giving messages about why they got the vaccine. I was on one of them. We had some infectious disease doctors down at the bottom here. And in the news, they were always on the news talking about the vaccine, just making it really, really accessible to people if they wanted to, get more information. We also hired a company to help us to reach other communities where they would, they would target communities that we serve. We have an extremely diverse patient population. Like we have people here from Cape Verde and, from Haiti, from Somalia, from Ethiopia, Vietnam, everywhere. And even in Eastern Europe, we have people from all over the place. And so we had people who, created messaging and targeting materials and things to all the populations that we serve. We also had sorority groups, as well, and others in the community doing pop-ups and knocking on people's doors and things. And so at this point, I'm going to pivot just to tell you what kinds of things that we kind of like had going on pre-COVID as another example of, how we were thinking about things even before the pandemic. We belong to something called the Healthcare Anchor Network. The Healthcare Anchor Network started about almost, but not quite 5 years ago, and started out with maybe 4 large hospitals like Dignity Health, which is now called Common Spirit because it merged with another hospital, I think it was Catholic Health Association or something like that, but they've merged to form Common Spirit, Kaiser, Trinity, and maybe another hospital. But now it's 65 healthcare systems across the country. And the goal, the mission of the Healthcare Anchor Network is to build more inclusive, sustainable local economies through hospitals being intentional about how they make decisions every day in hiring, investment, and procurement. And so what we were focusing on there pre-pandemic was economics. The things that we see, the patients who we see that I was just talking about, who live in communities that have been historically disinvested, what we are trying to do is turn those communities around, to transform those communities into viable economic communities where people have opportunities to engage in the economy through economic mobility and building wealth. So we were already on that path pre-pandemic. But even then, I can tell you, and I'll give you an example of how we even think about some of those things just a little bit different. In this state, when a hospital builds on it onto its present facility, the state says you have to give 5% of the total construction cost to the community. And we had just completed a campus redesign, and no one had ever asked the state this before, but we asked the state if we could commit our $6.5 million that we had to spend, if we could commit it to multiple different housing projects. And one of my colleagues, who I do a lot of this work with, Dr. Megan Sandel, who's a pediatrician, we asked the state if we could commit it to these projects, and the state approved it, which was a great thing. One of the things it enabled us to do was to invest in a private equity fund. We chose this fund because, unlike redlining in the 1930s, this particular fund will only fund developers if whatever they propose provides access to employment, green walking space, transit, healthy, affordable food, and affordable housing. And you get scored on that in order to be considered for funding. And so we invested in that, and it contributed to the development of this housing development here called Bartlett Place. It will ultimately be 323 units of new mixed income housing, some to rent, but also some to own. So there's opportunities to build wealth. And on the bottom level of that space there, people wanted a grocery store there. So we found this grocery store in Washington, D.C. called Good Food Markets. Again, we partnered with those owners because they aligned with our values. You know, they taught people to be entrepreneurs and things like that. And so we gave them a no interest loan. A lot of things we are doing are innovative. You know, we're doing different ways of even, funding, finding capital, and funding things like this. So we gave them a no interest loan to build a store out in that space. And one building is already completed, occupied. We had a second ribbon cutting for the second building about a month ago, I would say now. By us asking the state that, as you know, and I keep saying we're a safety net hospital, but this is Boston. There are a lot of hospitals in this town, a lot of well-known hospitals. And I will say that they have far more money than we when they're doing their determination of need. For example, we had $6.5 million. Children's Hospital, for example, had $53.4 million at the exact same time. But when they saw us get approval to do this, they saw that they could do something very, very similar. And one of the things they did, in addition to the independent things they chose to do, they actually invested with us. So the Brigham and Children's and us invested together to create an innovative, stable housing initiative. And that has enabled us to build on yet more funding through, like, JP Morgan Chase grant, for example, to do other things that one other thing I'll highlight in a second. This right here, for example, this is a place-based initiative that is working on employment, and not just regular jobs. I mean, not just jobs to be jobs, because we've done that before. When the mayor started his Boston Hires program, we were the first hospital to sign on, and we hired 400 people in this hospital that year. But now it's different. We are bringing in people with an intentionality. We have a certain baseline rate for jobs in terms of what people get paid. And we have an intentionality around providing people with supports and structured programs so that they get professional development and rise through the ranks in the hospital to leadership jobs, directors' jobs, and that type of thing. And the other part of it is housing preservation and acquisition. And now I just want to go right back to that grocery store. And so COVID happened before the store opened, and the owners in DC said, well, it's not safe to travel, so we'll find you 2 local operators. Well, they found these 2 local operators for us, and the more we got to know these local operators, we started thinking different. We thought, well, why should they be operators? Why can't they be owners? And by the way, why can't they own the bricks and mortar? Because it would mitigate the chance that they would get priced out of the lease when the lease was up. And that meant everything they invested in the store, they would lose it. And so that's the conversation we've been exploring with other co-investors at this point. So I've given you a background on who we are, what we've done historically, how those things didn't necessarily alter life course trajectory for people, despite how innovative they were. And I've talked about how we try to move beyond that and to actually focus on things like economic mobility and focus on the things that have created systemic barriers. But now, even with all of those things, we have a very, very different focus, because this sort of reckoning that happened over the past 2 years, for some reason, it really helped people to really understand things that were in plain sight to them all along, but they never interrogated these things and never understood how those things happened, and that in fact, those things were like created. And so that reckoning impacted the way that we have thought about this whole notion of equity, because as you know, over the past 2 years, people are hanging out equity banners. Everybody's saying, you know, they're committed to equity. And I believe people really are. But one other thing I realized over the last 2 years, people really did not know. They really did not know about inequities. They would be seeing them right in front of their eyes, but because it was such the status quo, it looked normal. And so they just didn't question it. And so the way we started 13 months ago, having this discussion about equity and how would we actually approach this. So we worked through a lot of things, but I can tell you where we started. We made a decision to start with ourselves. We made a decision to look internally at ourselves, to see where we might be complicit in doing things, operationalizing things that don't represent equity. So we looked at procedures, outcomes, policies. And the first thing we did after that, the next thing we did before we started diving in and looking at the data, is to establish principles. And these principles were established because we knew we might find some hard things. And we said, and we committed to there being no naming, no blaming, no shaming, but that we would support each other in this space and support each other in learning, and so that we could be able to proceed without trepidation. And our approach after these months and looking at things, and boy, have we found things. Our goal is to advance racial health equity by moving upstream, you know, looking at all the systemic things to ensure equitable care. So, you know, you have seen these on the left, and the way that we approach internally looking at these things are, and how we will implement what we will do are the things on the right. The one thing I can tell you that we decided we would do is this would not be a simple project or a simple initiative. This would be an enterprise-wide transformation. This would be the way that we would operationalize every single thing that we do henceforth. And so we brought these 80 leaders together, and they all represent all these bullets on the right-hand side, everything. For example, research, we will have community members, you know, vet the research, even the data, because you can only interpret the data based upon like what you know. You know, and if you have no insight into certain things, you know, your interpretations could be limited. We looked at, as you can see, more than 100 various different analyses, and we conducted lots of patient interviews. We developed a long-term vision, you know, we divided up into like 6 work groups, and we came up with some actions that we want to achieve over the next 12 to 24 months. We are about to announce what it is we've come up with, what we're going to call this whole thing. I don't have the permission to talk about that right now, but in another week or so is when this is going to happen. So once again, we're going to cover all these various different areas here. Again, economic mobility, housing. We looked at, you know, the areas that have the highest inequities, you know, like chronic diseases and infectious disease and maternal and child health, behavioral health, all those various types of things. And, you know, this is what we plan to do. the journey that we're on right now. And the light colored blue areas on the right is how we plan to address these things, the areas that we plan to cover. And once again, as I was just saying, the things that we will focus on are these 5 things at the bottom as we start. We have already done some digging and we've found some stuff. And we now know that we have a model that we believe will be transformative, because we started out by looking for inequity versus starting out with equity. We wanted to make sure we understood what inequity was before we came up with what equity, how we would operationalize equity. And I do believe that's the last slide. Yeah, that's the last slide. So I'll stop sharing. And thank you for your patience. I appreciate it very much. I don't know how long I took, but hope not too long.
Thank you so much, Dr. James, for that moving and enlightening lecture. I know that there are several questions that have come in, and so we can move now to our Q&A period, where we now have the opportunity to engage directly with our distinguished speaker. Please feel free to submit your questions for Dr. James via the Q&A box at the bottom of your screen, and we ask again that you please avoid using the chat box to submit questions. It is now my pleasure to introduce our Q&A moderator for this evening, Dr. Michael McGravy, who is Assistant Professor of Religious Studies and Director of the Institute for Theology and Pastoral Studies.
Dr. James, thank you so much for that very intriguing and informational presentation. And because this is a cultural topic today, I do have to ask this question. And I was thinking here of Dr. Max Goodwin, the fictional character on NBC's New Amsterdam, a favorite show in our household. So let me frame it with that. So your description of Boston Medical Center reminds me of NBC's fictional New Amsterdam, where Dr. Max Goodwin creates program after program to address perceived needs and equities. Not all of them are financially sound or successful. And the recent episode actually had a proposal like Good Foods Market that you mentioned just a moment ago, where they offer clean food opportunities in an otherwise fast food neighborhood. The long-running Grey's Anatomy and Chicago Med have also addressed the COVID and social pandemics during the last year. So most of what they've produced, even with Hollywood liberties, have remained as factual and realistic as possible. Meanwhile, social media platforms continue to spread misinformation. So my long-winded question, how has traditional media like these shows I mentioned helped or hindered medical clinics and outreach efforts that you and others in Boston have done?
I think they've done both. It depends, it depends, for people who were approachable and open and, on the fence, undecided. And if they were influencing people with correct information about the vaccine and COVID, it could pull people over to accepting the vaccine. If it was spewing, things that were untrue, telling people that it'll change your DNA and, cause infertility and all these other things, it might just, it just might make things worse than they already were, or just sort of underscore these things that, people were hearing and believing already that are untrue. So I think they've done both. It just depends upon where the listener or viewer is and what the message is.
Thank you. As a result of BMC's success with COVID-related intentionality, what are the biggest learnings that BMC will introduce to your quote-unquote normal services?
Yeah, we will have greater intentionality. We know that we can actually achieve something more than, we probably thought was achievable. I won't even say is that it may have been that we thought it was achievable, but I think people it just wasn't obvious to people what the root causes were of what they've been seeing for decades. BMC is a very bold place and a very creative place. So I think, I know, had we known sooner, we would have done something sooner. I mean, let me just be transparent. Not some people knew, but not everybody knew. But now everybody knows. And, there may be some people who might be skeptical, but, here and now, everybody's rowing in the same direction. And we are really excited, to get on this road. And I think being able to provide access the way we did, create access, and not just accept the fact that, oh, these vaccine sites are not proximal to where our patients are, and just just accepting that, but no, going out and creating the access. And we also ask the patients, what works for them. I can tell you, you can never go wrong by asking the patients, because we don't know what's best for them, only they know that. And it isn't good for us to be paternalistic in that way and think we know what's best. People know, what's best for them, and they are able to have the same choices that the rest of us do, just like you decide what works for you, because in the end, that's how their behavior is going to, that's how it's going to play out in the way they behave. You can ask them to do this or that, but they're going to do things and prioritize it the way that it works best for them and what matters most to them. One of my colleagues said to me last month, I found this organization that can really close the gap help people close the gap who are trying to become first-time homeowners. When they don't have the money to pay the down payment, they can actually fill that capital gap for them. And then this person said, but they share the equity. And I just looked at that person and I said, is that a deal you would take? And, and the person had nothing to really say. And they're like, oh yeah, well, I was like, well, if it's something you wouldn't take or you wouldn't recommend to your family, ethically, I can't recommend that to someone else. And obviously there's a market for it, because some people don't know what they don't know and they're desperate and all this other thing. And so, I just, but it's a really lighthearted way to help a person see what inequity is and how easy it is to not recognize it, So using examples like that in real time, it really helps people.
Thank you. Another question, enterprise change is hard. How is BMC Health System getting all of the 80 leaders on board with this enterprise-wide intentional effort?
It's a good question. This is a place that you don't have a lot of people jockeying for. We work very, very well together. There are not a lot of prima donnas and things like that in this place. There's no room for it. It's a safety net hospital. There's just no room for that. And so we generally support each other and work together. And we're also always doing something different. But I think no one has pushed back yet, and we made sure we got everybody involved. We got 80 leaders in the hospital involved, all the, chairs of departments, even our board of trustees, is involved. Everybody's involved. And by the way, this whole, the foundation of this transformation, this approach to equity came from our COO, and so underscored and, co-championed by our CEO. And so it's coming from the highest spaces. So nobody's pushed back so far.
You mentioned that your housing initiative drew the interest of other Boston area hospitals. Do you see other Boston hospital systems, Mass General, Brigham Young, following the lead of BMC to innovatively tackle healthcare initiatives?
Well, certainly in probably more than the housing space. And I'll tell you why. Something in 2019 happened that was very important and will help answer that question you just asked. So the Affordable Care Act says that hospitals across the country, every 3 years, you have to conduct a community health needs assessment. And based upon what you find in the community health needs assessment, you have to create a community health improvement plan. And all of the hospitals would, do these, we call them CHNA, these are acronyms for community health needs assessment and community health improvement plan, CHNA CHIP. And so, but in 2019, this is the first time this happened in the country, I think, all the hospitals did one together, which was the first time that ever happened. These hospitals, we met for about 2 years to create the governance and all this stuff to do it. But we conducted this thing together. And the 4 pillars that emerged from the assessment were housing, finance and economic mobility, behavioral health, and access to things like childcare. And there are 4 separate work groups, and we're all together working on that stuff together. Another thing that happened in 2018 was Medicaid changed from being a fee-for-service model in Massachusetts to an accountable care thing, which means that you get paid for success. You get paid for reducing hospital admissions and ER visits and things like that. And everybody kind of knew that the patients were people on Medicaid. That says something about the patient right away because they're on Medicaid. And people knew that they had other challenges. And so they were going to have to address those social challenges to be able to succeed financially as a hospital when your payer was Medicaid. We are the largest payee for Medicaid in Massachusetts. And so that helped all the hospitals to form this sort of ad hoc social determinants of health group that is now, like, I guess almost 3 years later now, and we still meet once a month for 2 hours. And so there are a lot of different sort of forums that we work together on now. So to answer your question, for sure, yes, there are other ones, but we all have our certain kind of approach to these things. Like, I don't know if anybody else who started out by looking in your own house first for inequity. I don't know of anybody who started out that way, for example. In terms of like being in the community and having advisory boards and all this other stuff, everybody's sort of like doing that. And also investing in housing.
Thank you. A question that comes up that I'm thinking of here is, you are making these initiatives in traditionally redlined, as you described, neighborhoods. And there's 2 things that come to mind here is that 1, when we talk about education inequality, and 2, the comfort of a minority patient seeing a white physician. And then 3rd, we all know that there's going to be soon a shortage of primary care physicians, physician's assistants, pediatric physicians, et cetera. So how has BMC addressed that? Are they taking initiatives to do so?
What was the first thing, Michael? What was the first thing? What was the first thing?
Sorry about that. My phone was connected to the computer.
Yes, okay, it's fine.
So I'm wondering how BMC has, taken upon itself to provide care for patients who are reluctant to see, how doctors, let me rephrase this. How are you addressing patients that are reluctant to see physicians who are not of the same race or gender? And then has BMC taken initiatives to encourage education for minority citizens, residents, to go into fields like pediatrics and primary care?
Got it. Yeah. Okay. So, we have a lot of, we have summer programs here. Pre-pandemic, we would have summer programs here. We would host things where kids come and, they get to spend time in various different departments and things like that. We also had another connection to a high school and we had that pre-pandemic also, where kids would come and spend time in different departments. Some of them would get hired internally. The other thing we've done is an on-out active campaign over, I would say, like the last 6 years or so, to diversify, the clinical staff in the hospital. And I would say in terms of the medical school numbers are kind of like almost 1.5 times, almost twice the national numbers for, diverse students in the medical school. And we've definitely tried to do more on the faculty side, the attending doctors and as well. So it does make a difference on some level, I mean, as a doctor myself, a doctor of color, I mean, from the time I've been a medical student, you walk in a room and sometimes you have a patient of color and they'll just like tell you, I'm so proud of you, or they'll say something like that, So, I think it kind of makes a difference. But in general, if you respect a person and you listen to a person and, you just want to hear what they have to say, because what I've noticed is that when people arrive in the ER, they come with all kinds of emotions, fear, angst, sadness, anger, all kinds of things, depression. But you get to be that person who's facing that person. You get to be that person who can actually shift their perspective. And it happens just from like listening to them, having no agenda other than to find out what matters to them and how this thing happened to them. And you can see the transformation happen right in front of your eyes. They just start like just coming down, just chilling and feeling better. And in many cases, they just become inconsolable, just because somebody actually just is listening, So there is a skill to that in case you happen to be of a different race or something, and it's a human skill to me. It can happen anywhere, outside of a healthcare environment even.
Thank you. What obstacles did you encounter in making an effort to look at equity internally? And did some internal stakeholders feel that it was too close for comfort?
Nobody has said that yet. Nobody has said that yet. And I will tell you, one of the places where we found the aha moment as we were digging for things, that department has led this whole thing in terms of this is exactly what we should be doing. And look at what we found and what it led back to, because sometimes you can see this gap or whatever, and you can say, oh, of course there's a gap. There's going to be this way for white patients, this way for Black patients. But we didn't stop there. We said, okay, let's see what's associated with that. And then we say, oh, well, let's see what's associated with that. And sometimes you can roll it all the way back to something like subjective decision-making, based on race, and so, one of the places where we found that department has been leading this whole thing. They've been the ones out there telling the story, internally. It'll be external soon, but they've been telling the story. So no, I mean, I think when we set up those principles in the beginning, I think it really, really helped. And also the culture we have here. We don't have a culture of shaming and blaming and things like that.
Okay, so there's a question here on vaccination, and I'm going to combine it into two here. So what is your message to those who are still hesitant to be vaccinated? Should all objections be respected equally?
I think Michael's frozen, right? I'm sorry. Well,
Religious leaders to help. I think I froze there. So
yeah.
Okay. What's your message to those who still are hesitant? Should all objections be respected? And then how important was it to BMC to get those religious leaders on board, especially when others are promoting misinformation?
Right. So it was incredibly important for us to get those faith-based leaders on board. And because we knew how many of our patients, are associated with those various different, faith-based organizations, our churches. and how many of them, believed in their pastors, and, did they just, is there, they're very faith-based oriented. So we knew it was really important. That would help a large number of people. And, I feel like people, what I tell people is to make sure you get information. You make sure you do your homework. You can make any informed decision you want, but make sure your decision is informed, and it's informed by, reputable sources. I'll be honest with you, I was hesitant in the beginning. Now, I was hesitant because I didn't trust the healthcare system. And what I didn't trust about the healthcare system is what I see happening in it every single day, And so, but here's what took me to the other side. At the time, I happened to be on the mayor's health inequities task force, starting from like March of 2020. And we would meet weekly. And every time they would talk about rolling something back, closing down something, I just would like, one time I just verbalized it in the meeting. I was like, every time this happens, I think about all these people who now, here's another person who can't work. Here's another person who can't take care of the family. Somebody else that can't feed, although I'm a doctor, I know that it was safer, but it's like, it's just not right. And a lot of these things that, it's like anything else, they were like giving people more money for unemployment and this type of thing. But when they did that, they would also take away food stamps from some people, it's like classic stuff they were doing. And so at one point I said to myself, I am not suffering. I'm not hungry. I'm not worried about where I'm going to live or whether I'm going to have food to eat. And if anything could work, probably it would be a vaccine. And I just could no longer live with my own self. I was like, the least I could do is take the vaccine, just in case it works. That's the least I could do. And I'm a doctor. So I made that decision to take it. And, they had assigned us dates to get our first shots. And every day it got closer and closer. And I was like, okay, I got to figure this out. I got to do something. And that's just what made me take it. And when I made that decision, the mayor's office, they sort of made me do a press conference. And I did. I told them, I was like, here's why I was hesitant. And this is what made me change my mind. Because I told them that, I understood the science, I understood the data. I just had an issue with the healthcare system, And so, but I told them also, that I just couldn't live with myself, when I wasn't suffering. And so that's sort of what got me over. So I respect people's decisions. I just feel like they should have all the information before they do that.
Thank you. A mission-related question. So what has the experience for you been like being a mission leader in a non-religious organization? And what's the relationship between mission, faith, and medicine?
Mission, faith, and medicine. It's interesting. My CEO created this title for me, and not until she did I realize it was a title you see in faith-based organizations. And there is definitely a connection because so many people, patients will tell me, since I've been an intern, they can have blood pressure about to give them a stroke in the next 5 seconds. And they'll say, no, God will take care of it. I don't need medication. The Lord will take care of me. And what that says to me is that's how strong a person's faith is. And for this context, for me, I recognize that I have to respect, what matters to people. And I'm married to a theologian, but I have to respect what matters to people and respect what people most respect, and that's how they're going to make their decisions. And so I realize that there's a strong connection between faith and medicine without question, at least in the context, that I work in. Many people, will, they trust their faith, but they don't trust healthcare, So there's definitely an interconnection, and I just respect it. And I tell my colleagues all the time who don't understand that, but I tell them all the time, you know, sometimes you walk in a patient's room, they got a Bible sitting right there on the table. They're already giving you a signal. You need not go in there and try to like supersede what they believe or what matters most to them. So, you know, they're giving you clues, you know. So in my context, I think there's definitely a connection for sure.
Thank you. How can we better meet the needs of patients whose lives are so very different than our own? And this is helpful for our nursing students here.
I would say always defer to them, always listen to the patients. I often would ask a simple question: what would it take for this to not happen again? Whatever they come in with, what would it take for this to not happen again? And particularly for the people who come in over and over and over again, I just ask them. And then that's how I learned about prioritization, what people were prioritizing in things. I mean, they'll tell you. We've had people who say, I just want a job. You know, they can't even get people who are trying to help them to take their medicine and come to their appointments. They can't even take that special attention. There are people hired to do that, but they will tell these people, I just want a job. And these are people who like live in a shelter even. And then these people start helping them find a job. And then when they help them find a job, then they can pay attention to the other stuff, you know, the medical stuff. So I would say have a clean slate in your mind. Don't have a narrative in your mind. You know, no preconceived notions. Don't try to figure out what you think is wrong or why this person is always unstable, because you're probably, it's like rolling the dice because you have no idea. And it's too easy to ask. And so that's what I would say, because you can never go wrong. And people appreciate that level of respect and that level of caring. You know, they appreciate that and they respond well to it.
So can you talk a little bit about mental health? We've heard our physicians, our ICU nurses, our physician's assistants, you know, members of my own family who have undergone either lengthy or abbreviated times in the ICU during the height of the pandemic. But not only their mental health, but the mental health of the patients that you encounter, the stress that they're under, the anxiety that they experience. So one, what has BMC done to address that? And also internally, among your physicians, your nurses, your PAs, how have you addressed mental health internally in the hospital?
Yeah, we have, so many different offerings to internally for staff. We have lots of it. As a matter of fact, even pre-pandemic, we were reaching these high levels of burnout and things like that. And this year's review of it, it has dropped, you know. So there's that. I will also tell you that somewhere between 74 and 80% of our patients have some sort of behavioral health disorder. You know, like a mental health disorder. I mean, high rates. Before the pandemic, when there were inpatient appointments in our behavioral health department, the no-show rate was something like 70%. And during the pandemic, when we started using telehealth, it flipped. We had like a no-show rate of maybe 20-30%. And so there was a lot of messaging in that, you know. I mean, you wonder, you know, was the stress so much higher, or is that a better mechanism? You know, is that a better model of care? You know, for them, is it easier for them? I mean, you can easily say that, they can just speak from wherever they are on a phone. They don't have to try to need money for transportation or go through whatever they have to go through to get here. But the no-show rate went down significantly. And I guess the more important point was the show rate was like through the roof. It was amazing how that actually happened. But we are very, very cognizant of stressors and things like that, you know, people have. I mean, there was huge burnout pre-pandemic, but even worse afterward. You know, people were just exhausted. And also, impacted by what they were seeing. You know, people dying by themselves, families couldn't be there, and you know, those types of things. It was tough to see day in and day out. Going home, my spouse and I lived in different parts of the house, you know, because of me being in what was deemed, I forget, I don't know, some kind of radiation exposure or hotspot or whatever. But and a lot of my colleagues did that, you know, with their spouses. They lived in different parts of the house, or, you know, had to like undress outside or whatever to get in their homes and all that.
Yep. Again, personal experience. I remember those days, and it was hard. It was hard on our kids not to be able to, you know, hug mom when she came home.
Right.
So another question: are race and class co-determinants of healthcare disparities, or is socioeconomic stratification the real culprit?
Good question. Well, one begets the other, quite frankly. I mean, because so many of the you know, the things that have created class, at least not across the board, okay? Because you think about, you know, there were various different white ethnic groups that were not considered white at some point, you know, really early on. You know, I don't know, you know, like they had these ghettos, if you will, in New York, you know, various different ethnic groups coming from Western Europe. But those people have been able to climb out of that. And so that too is based on race from my perspective and from all the things I've ever read. But I'll put it in the context of what we're talking about now. It's like, I think race, you know, systemic racism, you know, has created, you know, poverty for people in many ways. Has created like poverty traps for people, and created this, you know, socioeconomic sort of, you know, I don't know, whatever to call it, but, you know, this spectrum, you know, in our country. And and continues to do so. You know, even if you think about things like public housing, you know, you live in public housing, and not everybody who lives in public housing, it's not like there are no white people in public housing, right? But, you know, you have to earn a certain amount of money. You're capped as to how much money you can earn and still live in public housing. So, you know, people turn down raises and turn down promotions because, you know, they don't want to lose the housing. And I'm not saying you should be able to earn as much money as you want and stay in like subsidized housing. I'm just saying you need a runway of sorts. You know, these subsidies aren't designed for people to get out of them, which is what they should be. They're just traps. So that could be better designed, but and actually would be a better business model if people could participate in the economy versus rely on it to take care of them, you know? Anyway, to answer your question, I think one begets the other. I do think, you know, structural racism is like a real, you know, unquestionable cause, you know, for poverty and the various different disparities that we see in the country, for sure.
It is amazing, you know, one of the statistics that I remember from grad school is that African Americans have only gained 0.5% of economic growth since the Civil War, you know, and I mean, that's an amazing statistic to consider how poorly we've done as a nation. On behalf of all of us, Dr. James, thank you so much.
Thank you. Thank you so much for having me. I really appreciate it. I'm grateful to you all. And thank you for all that you're doing. Thank you so much. Thank you so very much.
Thank you again, Dr. James and Dr. McGravy, for that wonderful Q&A session. Again, on behalf of the St. Augustine Center for Ethics, Religion, and Culture, please join me again in thanking Dr. James for her exceptional insight on these timely issues. Dr. James, we are all in your debt and look forward to inviting you back to campus in person at some point in the future.
Thank you.
As a reminder, tonight's inaugural Distinguished Lecture in Culture has been recorded and will be available on the Elms College YouTube channel within the next few days. Thank you for joining us. and have a wonderful evening.
Thank you.